This lecture is on traumatic cardiac arrest. So traumatic cardiac arrest, different than medical arrest. So it's when you've had a cardiac arrest from some sort of major trauma, and it has very, historically very poor outcomes, less than 1% survival. And it's important to understand that if you've had a cardiac arrest from trauma, the majority of the time it's not going to be survivable with any treatment, even if it happened directly outside a trauma hospital's resus room. But there are a significant subset of survivable arrests, or potentially survivable arrests, and those are the ones that we aim at. Obviously, arriving at a scene, you can't tell which arrests are going to be salvageable and not salvageable if the person's not, clearly dead, brain matter exposed, or just injuries completely incompatible with life. So we always start, but we will never achieve extraordinary outcomes with these patients. So because of that low rate of survival, there's been a bit of a culture over the last several decades of futility with traumatic arrest, where you're just going through the motions with the full expectation that they're going to die. However, a lot of the studies that those very low survival rates were based around are now quite old, up to 30 years old, and both emergency, like pre-hospital skill sets, as well as hospital interventions have progressed since then. Now, the Europeans are worth mentioning here. So there's more recent data out of Europe that showed quite high levels of survival and traumatic arrest, different across the different studies, but with an average of maybe 7-8% survival. And it seems to be down to two factors. One is that Europe is very dense in its population, so its response times are quite short. 6 to 7 minutes is an average. In Australia, it's much longer than that. And in Europe, they have doctors on their ambulances. And as we'll get into in this lecture, a lot of the interventions that are shown to improve outcome in traumatic arrest at the moment are only done by doctors. One of the reasons we have poor outcomes in Australia is that we can, by the time we get a patient off the road, get them to the hospital, we might be looking at 30-40 minutes before these interventions get done. It's too late. So in Europe, they're doing some of these things on scene. So there are 3 reversible causes from a traumatic arrest. You remember these from when we did multi-trauma. You can have an obstructed airway that can either be due to profound unconsciousness, having the tongue flop back, or due to blood in the airway, a tension pneumothorax, or exsanguination from blood loss. So starting on the airway, there are a couple of things we can do for that. You can manually open the airway. Just a double or triple airway maneuver will displace the tongue. And you can maintain that with just an OP. Now, if the reason this person had arrested or a contributory factor to their arrest was simple hypoxia, just due to tongue obstruction, that's all you need to do. You open their airway, put an OP in, and you might be able to get them back just off that. We can insert a supraglottic airway, like an LMA is what we use in Australia. And if a CCP is attached to the case, which they often will be, they can put a tube in or do a surgical cricothyrotomy, a surgical airway, which is often for trauma is the best option if they've got facial trauma or broken jaws and stuff. For tension pneumothorax, we can use a 14 gauge cannula. We've switched over to these ones now, which are much longer than the 14 gauge IV cannulas. Or CCPs carry the Cook pneumothorax set, which is again very similar. It just has a valve on the end of it and a very long 14 gauge needle. An intervention that currently is done by Haru in Queensland is the finger thoracostomy down the bottom, which again we went over in multi-trauma. This is one of those very strongly evidence-based interventions for traumatic arrest that we know dramatically improves outcomes. So if someone's having a tension pneumothorax, this is the pre-hospitally definitive treatment for it that will relieve the tension pneumothorax and overcomes a lot of the problems that you have with the needle decompression, such as blood clogging. This is again one of the reasons why the Europeans have the good outcomes, is that's well within the doctor's scope of practice, so they're able to do these things pre-hospitally rather than leaving that pneumothorax only minimally dealt with by needle decompression until they get to an ED. They just do it on road. So again, we're hoping that may be something that rolls down to paramedics and traumatic arrest in the future. Okay, reversible causes bleeding. So you have blunt versus penetrating trauma, and they can just as easily be the cause of the traumatic arrest. Penetrating trauma has better outcomes, and the reason is that if you've had some sort of penetrating trauma, you generally only have a relatively small amount of your body that's involved. So if you get shot or stabbed in the chest, your chest is what's damaged. So often you've just got one thing wrong. If you've been stabbed through the right side of your chest, you may have attention in the thorax and nothing else. You don't have that airway compromise. You don't have that exsanguination. Blunt trauma tends to cause widespread injuries, all throughout your body: head, chest, abdo, extremities. And because of that, because it's so multifactorial, it overall tends to have worse outcomes. You need, what you're going to do about bleeding depends on whether external or internal. So external bleeding, tourniquets, pad bandage, the Israeli trauma bandages. Internal, we're looking at splinting, particularly pelvic splinting. That's really going to be the lifesaver, because you can lose so much blood out of your pelvis. And in terms of volume replacement, for a patient with very low blood volume or who's exsanguinated, you won't be able to get IV access on them, most likely, because their veins are collapsed. So CCPs can put intraosseous needles in, IO needles, and the humeral head almost functions as a central line. Normally an IO placement site will be on the tibia, which is a stable site, which is why it's preferred, but it's not that vascular, and you can't put that much fluid through it very quickly. A humeral IO, you can put a large volume of fluid through quite quickly, and it gets into the circulation quite fast. For traumatic arrest, we want to do volume replacement using normal saline at 20 ml per kilo. So if it's a 100 kilogram person, we want to give them 2 litres. So you want two IVs or 2 IOs, and then a litre bag hung for each. So how to actually deal with a traumatic cardiac arrest? So you arrive, you find that the patient's unconscious, so DRC, AB in that case. You identify that there's a likely traumatic cause. You'll have that from the history and from the initial presentation. So that then you check their pupils disability, cardiac arrest, so they'll likely be fixed and dilated, and you want to expose them. Then you want to do hemorrhage control is your first priority, external hemorrhage control. So trauma bandage or tourniquet, if you can see any external bleeding. Then in order of attack, you want to secure the airway. So that can either, I put LMA in here, but it can honestly just be a triple airway maneuver and an OP airway. If you're able to ventilate the patient with that, that's fine. Bilateral needle thoracostomy, so needle decompression, and then 2 IVs and start fluid replacement at 20 ml per kilo with normal saline. After you've done those things, you want to have some other considerations. If it's blunt trauma, like a patient's been hit by a car, they are going to need a pelvic binder. If it's penetrating trauma, if they've been shot or stabbed, you want to transport them, particularly if they've had thoracic trauma. You want to think about transport, because there may be things like cardiac tamponade that we can't do anything about, but at hospital they can actually do what's called a clamshell thoracotomy, where they cut through the sternum and crack the chest open, just like a clam opening, and it gives the doctors full access to the heart and lungs, and they can patch bleeding and release tension in the pericardial sac if there is blood in there. Now CPR. So there is no real theoretical reason to do CPR in a traumatic arrest until the life threats have been dealt with. So if a person is having, if a person has a tension pneumothorax and the heart is being crushed by the lungs, then it can't refill and it can't eject blood properly. So doing CPR is not going to be that helpful, because you're just going to continue to squash the heart even more, and when you release, it can't refill anyway because the lungs are crushing it. If a person is hypoxic and has an airway obstruction, circulating completely deoxygenated blood is not useful. You need to correct that airway obstruction. And if a person is exsanguinated, then doing CPR is useless, because there is no blood to enter the heart and no blood for the heart to eject. So there is a place for CPR in traumatic arrest, but it's only after those things have been dealt with. So it feels very strange to do a cardiac arrest and not do CPR when the person has no pulse, but you need to get that LMA in, decompress, IV access, and get some fluids hung. And at that point, you start CPR if there's two of you. If you have more people or if you have a bystander available, they can absolutely do CPR from the start. It's not contraindicated by any means. It's just not the best use of your time if you've only got two people. Get both people attacking the life threats before CPR is commenced. Now, the vast majority of traumatic arrest patients will have a PEA, so a pulseless electrical activity, or a systole. This is different than medical arrest, where you'll frequently see a VF and then occasionally VT. So the rhythm is fairly prognostic of outcome. Asystolic presentation, so if you arrive and the patient's in asystole, has a very, very low survival. And PEA is prognostic of outcome depending on its structure and its speed. So if you have a slow, wide PEA down here, particularly if it's under 40 complexes a minute, that's pretty prognostic of a poor outcome. That person's probably not going to survive. If they've got a PEA faster than 40, even if it's wide, that shows that the body has a little bit more in it, and the person is going to potentially have a better outcome. But the real one that you want to look for is the narrow complex PEA. So it'll just look like a sinus rhythm or a sinus tachycardia. If you see a narrow, reasonably fast PEA in a traumatic arrest, the person is pulseless, but that's their rhythm, that's strongly suggestive of a reversible cause. So that's a person who's potentially salvageable. You want to treat them very aggressively, get that LMA in, decompress those lungs, start giving some fluid, and if anyone's going to come back from a traumatic arrest, these are the ones that may.